So let's start this morning by talking about asthma. And many of you may remember from yesterday, I said that in the world of primary care, there is no guideline that's really turned the disease state management on its head like the ones that have come out with regard to asthma. So what we are going to do this morning is we are going to talk just very briefly about some of the latest statistics as they pertain to asthma, and then really just jump into the guidelines and the pharmacology and how are we now managing these patients with this condition. But before we get started, I'm going to pose two pre-test questions. Again, you don't have to answer them aloud. Just think about them, and we're going to revisit these at the end of the program. So which of the following is true about the use of anti-inflammatory therapies, i.e. corticosteroids, in patients with asthma? Is it A, systemic corticosteroids are an effective, low-risk method for treating most asthma exacerbations? Is it B, anti-inflammatory airway effects of inhaled corticosteroids do not occur until 2 to 3 days of consecutive use? C, for patients with mild asthma, SABA-only rescue therapy is preferred to ICS-containing rescue regimens due to improved outcomes and lower corticosteroid exposure. Or last, letter D, adding an ICS to a fast-acting bronchodilator for rescue or rescue and maintenance therapy results in lower exacerbations when compared to a SABA-only rescue therapy. So keep that in mind. We'll revisit them at the end. And the next question, which of the following is true about the use of SABA in patients with asthma? Is it SABA-only rescue therapy is recommended for patients with mild asthma, step 1 in the GINA 2022 report? Is it increasing SABA use is associated with a higher risk of exacerbations? SABA and ICS rescue therapy is equally as effective for preventing and treating exacerbations in SABA-only rescue therapy. Or last, there are currently several FDA-approved SABA-ICS combination inhalers available in the United States. All right, so let's get started with some discussion about asthma. One of the things that I often teach when I'm teaching the NP certification course, trying to help NPs pass their boards, is I often say to the NPs, when there are multiple guidelines out there, focus on the commonalities. What do the two guidelines really agree on? And one of the things that both guidelines agree on is that asthma is a heterogeneous disease, that it's caused by a number of different interleukins, eosinophilia. And now what we're actually seeing are people who are developing asthma because of intra-abdominal adiposity. That visceral adiposity that's located below the abdominis rectus muscle is an active endocrine organ, and it triggers the release of a number of inflammatory mediators, including interleukin-6, which we believe is why people who have visceral adiposity are developing asthma at increased rates. And they're often very difficult to treat. So there's no one shoe fits all, one size fits all in the world of asthma any longer. But what they do also agree on is what triggers the symptoms of asthma is airway inflammation. So whether this person is acutely exacerbating or whether they are chronically affected, it is inflammation that causes the symptoms of asthma. The mucus production, the airway hyperreactivity, and the symptoms, the coughing, the wheezing that go along with asthma. So as we're thinking about asthma, the underlying strategy today is what can we do to mitigate and affect inflammation? It affects over 339 million people worldwide. And we know that despite significant advances in our guidelines and in our treatments, it continues to have a significant health burden. In fact, it is the most common chronic condition of childhood. About 19 million people in the United States are affected by asthma. And over the past decade, we've seen almost an 80% increase in asthma diagnoses. So people will often say to me, well, why is that? I think it's probably multifactorial. One, I remember when I first became an NP over 30 years ago, to diagnose asthma, we didn't have portable spirometry devices. Everyone had to go to pulmonology, or they went to the hospital. They had their methacholine challenges. They were in these big chambers to diagnose. Those days are over. We have portable spirometry devices now that cost us about $1,000 a device. And we're able to walk around with these, hook them up to the EHR, and import the data right into our EHR system. So it makes the diagnosis a heck of a lot easier. But we also know that there's that changing pathogenesis of childhood infections that is increasing the risk of asthma as well. Also, some people even say, are we too hygienic of a society? Is that impacting people and affecting their inflammation and their asthma rates as well? But in any event, the rates are up, and therefore hospitalizations and ER visits are also up. Every year in the United States, there's over 10 million visits to a healthcare provider for asthma. There's about 2 million ED visits every single year. And I often feel like if my patients with asthma end up in the emergency department, I've really not managed them as well as I need to be, because people should have sick day plans. They should understand what to do and when to be seen so that they don't end up hospitalized or even dying from asthma. I said this to you the other day. The latest statistic is that over 3,000 people die in this country from a disease that we can absolutely manage. But the majority of these people are not being seen by pulmonology. They're not being seen by asthma immunology. They're being seen in primary care. And while I believe that this is a disease that absolutely, for most people, can be managed in primary care, we're not doing as good of a job as we need to be. And all of you in pharmacy, you're seeing this as well. People who are not filling their inhalers, you're seeing it on your end, and we're seeing it on ours as well. And by the way, the highest rates are in adults in terms of death. It's not children. Children tend to be a little more aggressively managed, but it's adults, and it's adults living in inner cities and in communities of color that have the highest rates of asthma death. So if you take a look here at this slide, what I really just want you to see is the trajectory of asthma prevalence. And you can see that over 2 decades, the numbers have gone up pretty significantly. So for many people with asthma, there is that genetic predisposition. It's been identified on a chromosome. So we know that there is a genetic predisposition to this. But then what happens is there's repeated exposures, whatever they may be, that in that person who's genetically predetermined or equipped for it. And they release, when they're exposed to those allergens, there's a release of the IgE antibodies. They bind to the antigen, they form the masked IgE allergen complex, attach themselves to the mast cells, and that's what triggers a lot of the release of different inflammatory mediators. In the past, we've always talked about histamine, but it's so much more than histamine. That's one of the inflammatory mediators, but there are so many more. Hence the reason you're seeing more and more biologics coming onto the market for those people with moderate to severe asthma that are not well controlled with traditional therapy. So this is how it looks in my clinic. Patients have genetic predisposition, something triggers it. For a lot of people, it's perfumes, it's exposure to tobacco. For others, it's a respiratory infection. That's a big one we see. For some, it's just exercise. When they exercise, they develop symptoms. Certainly cold weather. We have some individuals who have cold-induced asthma as well, but something triggers it. And there's 2 components that happen, or 2 things that happen when they are triggered, and that is inflammation goes up and smooth muscle dysfunction occurs, leading to that hyperreactive airway, that mucus production by those big goblet cells in the airway, and leading to all of that inflammation and certainly symptoms. But one of the main points I want you to take away from in this lecture is that poorly controlled asthma leads to airway remodeling. And over time, what we're seeing are people who are not well controlled, those airways become less reversible and they become more fixed. And in fact, we see a lot of people who have had asthma for decades who actually behave more like they have COPD. that when we go to reverse them and bronchodilate them with albuterol, they don't reverse by 12% or greater, which is what's required to make the diagnosis. These people reverse 1 and 2%, just like our patients with COPD. So it's important that what we do is we interfere with that inflammatory response, because that's what causes the airway remodeling. And over time, that fixed airway that we are seeing in patients with asthma. When my patients tell me with their asthma, I feel like I'm breathing through a straw, they're not lying. What happens is all of that inflammation triggers epithelial damage. There's vascular dilatation, there's goblet cell hyperplasia, there's mucus production, and there's lumen narrowing. Those airways become narrow. And look at this picture. It's a cross-section of a bronchiole, and it's a patient having an asthma exacerbation. And look at how that area, that lumen, ought to be much bigger. And you can see it's very, very narrowed and constricted. And look at the damage that long-standing, poorly controlled asthma causes. On the left-hand side, beautiful airway, big goblet cells, beautiful cilia. And on the right, this is the airway of a patient with asthma. There's so much damage there. And all of this leads to that basement membrane thickening and the reduced ability to bronchodilate and reverse. So taking nothing else away from this lecture, the underlying problem is inflammation. That is what triggers the hyperresponsiveness, the bronchoconstriction, and the symptoms of asthma. So let's talk about making the diagnosis of asthma. Let me start out by telling you about a study that was done at the VA Medical Center across the nation. They took 25,000 patients who had been diagnosed with asthma and COPD and were being treated with medication. They performed spirometry on them, and 60% of them had neither asthma nor COPD. If we are not doing objective airflow measures, we are missing and we are making the wrong diagnoses. And I want to share with you, for me, one of the things that I've done now for 27 years is I help to defend malpractice cases. And 3 years ago or 4 years ago, you may have read about a malpractice case in Oklahoma. It was a $169 million case. I worked on that case helping to defend the NP. But one of the things I want to tell you is about the first case I ever worked on, and it was a 14-year-old boy. He came in for a well visit to see a nurse practitioner in a federally qualified center in Connecticut, and he needed a sports physical to play sports. He was 14. He had been seen in the emergency room unbeknownst to the NP 2 times in the year leading up to his death. But he had been diagnosed with exercise-induced asthma and was given albuterol. The NP evaluated him. She noted a murmur, grade 2 out of 6 systolic murmur, mitral region, radiating to the left axilla. She called it benign. She cleared him for sports. First of all, benign murmurs generally don't radiate. You hear them in the axilla. They're usually a mitral pathology. But in any event, she called it benign, cleared him for sports, refilled his albuterol inhaler, and his first football practice, he was running laps and he cardiac arrested and died. On autopsy, his heart was 5 times bigger than it should have been. And they paid. That NP and that clinic paid out $21 million for that case. Now, the moral of the story is not one person had done any type of objective airflow measurement on this kid. And so it's what sounds like asthma is not always asthma. 2% of people who have asthma-related symptoms actually have underlying cardiopulmonary abnormalities. So I cannot emphasize enough the importance of making sure that we're using the treatment guidelines and we're using the tools that we have available to us to make these diagnoses. So let me walk you through a patient of mine. This is a 21-year-old female who comes in complaining of shortness of breath that occurs when she's running. It's been present for months. She says it occurs with coughing. It's accompanied by coughing, and she'll cough for minutes to an hour or so after she exercises. It's 3 to 5 days a week, and it only occurs when she runs. She denies any chest pain. She doesn't hear herself wheezing. She doesn't get dizzy. She doesn't feel like her heart's doing anything funny, but she's never been evaluated. She did have bronchiolitis as a child. RSV is the leading cause of bronchiolitis and 50% more likely to develop asthma later on in lifetime. She only knew she had bronchiolitis because she was accompanied by her mom, and her mom said, we were in the ER multiple times when you were sick as that baby. So she's a non-smoker. Her history and physical exam is completely unremarkable. She doesn't have any cardiac signaling. She has no murmurs. Her PMI is not displaced. She is otherwise perfectly normal evaluation. But what's important is that not only do we need to take that history and perform that physical and exclude those other abnormalities, that both of the guidelines say spirometry is recommended to make the diagnosis. They've now gone as far in the newest guidelines to say, we recognize that for some people, spirometry is not available, in which case peak flow meters may now be used if spirometry is not available. Now, historically, we've used peak flow meters for monitoring, not for diagnosing, but we can absolutely make the diagnosis now based on peak flow meters if we don't have anything else available. So as I alluded to, about 2% of people who present like they have asthma actually have some other cardiorespiratory condition that is not asthma. So the most common symptoms that we see are the coughing and the wheezing and the chest tightness. The people who say to me, every time I get a cold, it goes straight to my chest. I cough for weeks and weeks on end. My chest gets tight. And obviously dyspnea on exertion and shortness of breath. So why are they asking us to do spirometry? Because it's an objective measurement of airflow obstruction. Asthma is a problem of getting air out. It is a lower respiratory condition, and people have a hard time getting air out. So the first thing that falls with asthma is forced expiratory volume in 1 second. A normal FEV1 should be 80% or better of predicted. Is there anyone in this room that's ever done spirometry on yourself? If you've not done it, I think every healthcare provider should be forced to do spirometry. You literally feel like you are blowing out your lungs. It is so hard to do. Now think about these people who have a lower airway obstruction. They can't get air out. And I always know when spirometry is happening in my office because you hear the medical assistants, come on, blow. You hear them screaming because people need to be coached to not only blow fast, but also blow for as long as they possibly can. Because what we're looking at is the FEV1 for asthma, and we're looking at the FEV1 to FVC ratio for COPD. So we use those two components to help us to differentiate between asthma and COPD. Gone are the days that we're doing methacholine challenges anymore. We now have something known as fractional nitric oxide. It is a test that we can now use to measure airway inflammation through fractional exhaled nitric oxide. So instead of having to put these people through the methacholine challenges, the fractional nitric oxide gives us some indication of whether there's airway inflammation, and we don't have to subject them to those methacholine challenges. So those are kind of on the out these days. It's more spirometry to make the diagnosis, peak flow monitoring to monitor, and then a fractional exhale nitric oxide for people in whom we can't establish that diagnosis. So let's go to my patient. Her heart, lungs sound good. All of her vital signs are great. And on spirometry, she gives me, so we usually have them do 3 attempts through the course of spirometry, and we look at the quality. We obviously want the quality to be an A or a B. It is not unusual for us to see people have quality D and F. And when we get to those points, it's really hard to objectively evaluate their findings because the studies are just not great. There are truly some people who cannot do this. And we have 2 patients in our office who, when they do spirometry, become syncopal. So we've got a couple of asthmatic patients that we have to have sitting when we do spirometry, which is not ideal because if we have them standing, they have a syncopal episode because it's so hard for them to do it and they vasovagal. So let's take a look at this patient's FEV1. It's 72%. We expect that to be 80% or better of predicted. So when we blow out, we ought to be able to empty 80% of our air in the first 1 second. And that's the first thing that falls. What I've also given you here is the FEV1 to FVC ratio. We use that to diagnose COPD. If that ratio is less than 0.70 post-bronchodilator, we have our diagnosis of COPD. So under 70% COPD, under 80% of the FEV1, we're going to think asthma. So this patient's FEV1 is less than 80%, but now what I need to do, even if she's feeling great, is I need to give her albuterol. I need to look at that airway reversibility. So what we do is we still use nebulizers for this purpose. I don't stock albuterol in the clinic, meaning an inhaler. So what we'll do is we'll give them an albuterol neb, even if they're feeling great. We'll wait 15 minutes after the neb, give it a chance to be effective, and then we have them redo spirometry. If their FEV1 improves by 12% or more, and that peak expiratory flow rate increases by 200 mLs, or they have a 20% improvement in their FEV1, we have our diagnosis of asthma. And this is how we are making the diagnosis in primary care as well as specialty. Now, there are going to be people who will not meet that criteria. This is where we then start going down the road of getting the fractional exhaled nitric oxide little device they blow into to help us to further make that diagnosis, because this is different than what it used to be. Now, what if you only have a peak flow available? Do any of you have the app on your phone called MD Calc? It is my favorite app, one of my favorite apps. If you don't have it, MD, like medical doctor, Calc. Awesome app. It's free. And when we get into talking a little bit about Hep C, I use that app all the time to calculate out someone's FIB-4 score. So I can figure out, does this person have risk of cirrhosis? And do I need to worry that these individuals have cirrhosis? So great app in there. There is an app that'll allow you to calculate peak expiratory flow rate and change it into percent of FEV1. So let me give you an example. Let's say my patient, let's say I don't have spirometry. All I have in my clinic is a peak flow. And they're 20 years old. So I put their age into this peak flow calculator in MD Calc, put their age, their height, their weight, their gender into the app, and I hit calculate. And down at the very bottom of the app, it'll say patient at 20, gender male, this height, this weight, should be blowing out 500 mLs a minute. Okay, it'll give you the norm. So I do peak flow on my patient and they blow out 250. What percent of predicted is that? 250 divided by 500, 50%. So that correlates with an FEV1 of 50%. It's an easy way to do it if you don't have spirometry. It's not as great. You can't get your flow loops. You can't get all the other, the FEV1 to FVC ratio numbers, but you can at least get someone's peak flow if all you have is a peak flow meter and you can convert it over. So hopefully that's helpful. So let me show you what her spirometry looked like. So I've given you her baseline. I bronchodilate her. And what I see after bronchodilation, even though she's feeling great, is her FEV1 goes up by 18%. She's up to 90% of predicted. And her peak expiratory flow rate went up by 220 mLs. Do I have my diagnosis of asthma? Absolutely. 200 mLs improvement and a 12% or better, we have our diagnosis of asthma. Now, what do we need to do? The answer is what you do is going to depend upon what guideline you are operating under. The guideline I've used for decades is called the EPR4. This stands for the Expert Panel Report. Some of you may know this as the National Asthma Education Program. And what we do, if this is the guideline you're using, is we base our diagnosis based on symptoms and peak expiratory flow rate, or FEV1. If you're using GINA guidelines, We base our staging or diagnosis based on symptoms only. So let me show you how we use this. So if this is the guideline you're using, and this is the one I've used since I came into practice, and I only last year started to switch our clinic over to the GINA guidelines, but this is actually a fairly easy guideline to use, because one of the things that's really important in the world of asthma is to stage it. How severe is it? The severity of asthma determines how we treat people. So if I think about diabetes, if I walk into your clinic and I have an A1C of 9% or greater, and I am symptomatic, I'm peeing up a storm, ADA says you go straight to insulin. That those individuals, based on the severity, should be started on insulin that day. It is the best hope of preserving their beta cells. The same thing for asthma. The more severe they are, the more aggressive we are with their treatment out of the gate. So let's take my patient that we just saw, okay, that I just presented to you, and we are going to assign the level of severity to the highest level, that is the highest box that is checked, even if only one item in that column is checked. So let me show you. Intermittent means they have symptoms less than 2 days a week. Well, I told you she has symptoms 3 to 5 days a week. Okay, so that kicks us over here to the mild box. She doesn't awaken at night. Remember, our body's own cortisol levels reach their lowest point from around 12 at night to about 5 in the morning, which is why so many of our patients with asthma will have nocturnal symptoms. Cortisol falls, airway inflammation goes up, and airways bronchoconstrict at night. She doesn't have any nighttime symptoms, so she's still over here in the intermittent column. She also says it's starting to interfere with my running a little bit, so she would be minor. So we're thinking mild, but then I performed spirometry on her, and her FEV1 was 60 to 80% of predicted. Guess what? She's now a moderate intensity or moderate severity persistent asthma. Moderate persistent asthma. And that is the severity that she's going to stay for the rest of her life. So in her chart, it will say moderate persistent asthma, well controlled, and I'll describe that, but she is of moderate severity. What does that mean for her? It means when we start her on meds, we go straight to step 3 treatment, if this is the guideline you're using. And then you bring her back every 2 to 6 weeks until you get her well controlled. So she is moderate persistent asthma. Step 3 care is where I go with her. There is no indication in the world of asthma to order a chest film unless you suspect that they have a concomitant pneumonia. However, because asthma is a problem of getting air out, if you do order a film, just like with COPD, this is what you're going to see. You're going to see hyperinflation. How do I know that? All the black air being trapped in the lungs, but you'll also see that the diaphragms are low and flat. That's because when air is trapped, expands the lungs, pushes down on the diaphragm. Normally the diaphragm sits around the 10th posterior rib. So in people with asthma, when we're looking at films, we'll often see that their diaphragm is down around the 11th rib or below. And what you'll also see over time, and we used to think this was only COPD, but we're now seeing patients with chronic asthma who have increased AP to lateral diameters, or what we have called for years that barrel chest. So let's talk about how the treatment of asthma has changed. Raise your hand if you remember, we used to give people Primatene Mist. Any of you remember? And said to them, use it as you need it until you get in trouble. Because all of our focus in the 70s and 80s was let's just bronchodilate you and let's treat your symptoms. Well, I was just out of school or just coming out of school in the early 90s when the first EPR1, the National Asthma Education Program, first came out. And what they said is the problem's inflammation. We've got to reduce inflammation. And that happened in the early 90s. But then what has happened in the last decade is we have now started to focus on not just lowering inflammation, but preventing that remodeling and those fixed airway obstructions. And one of the studies that I find so interesting is this one. They took 119 children diagnosed with asthma in the 60s, and they followed these kids out for 27 years, checking in with them at different points in time. So now you can see that these kids are in their 30s and in their 40s, right? Well, what they found was children who had the worst lung function and were the worst controlled in childhood were adults who had the worst lung function in adulthood as well. So I use this with parents all the time. And I apologize that the colors did not come out on this as we transferred it over. All I want you to see, and I'll explain this to you, is that as we age, every year we lose FEV1. However, if we have asthma, that's this blue line, there's just a steeper decline in our FEV1. And if we smoke on top of asthma, that decline is even steeper. And these are studies in men with and without asthma, and then men who also smoke. So we know smoking also worsens this. So going back one more time to the EPR4 guideline, we can see one more time that our patient was moderate persistent. We need to go to step 3 in treatment. So now there are 2 guidelines that are out that we use to manage our patients with asthma. Many of you have heard of the GOLD guideline. That is the Global Obstructive Lung Disease guideline. That's the guideline that's been out for decades now to manage COPD. The attempt with GOLD is to globalize the treatment of a disease so that all around the world, the guidelines are set and we're all kind of using the same guidelines, albeit meds are different in different countries. The same thing has now come out with GINA, and GINA was released in 2022 with the goal of, again, globalizing our asthma treatment. So these are international guidelines, and then we have our own US-based guidelines that have been out since the early 90s. They get updated on a regular basis, and these are called the National Asthma Education Prevention Program, also known as EPR. So the major components of both of these guidelines is assessing asthma severity, and the severity is leading to the selection of the drugs that we're using. Number 2, assessing those patients for asthma control. 51% of people in primary care at this minute are not well controlled. And if they're not well controlled, they're at an increased risk for exacerbations, ER visits, hospitalizations. And for any of you that are in any type of value-based quality type metric programs in your clinic, one of the ways we get dinged and affected financially is when patients are using emergency rooms for inappropriate reasons. And we also get dinged based on cost and how much money each patient costs us. And at the end of the year, for our clinic, it's what allows me, if we're doing our work and doing it well, it's what allows me to bonus my team. Because for us, we collect $200,000 to $400,000 in quality bonuses at the end of every year. And I see that money, and we give that money back to our NPs and our medical assistants and nurses so that I can retain staff. So these are really important to me. Plus, also what's important to me is to make sure that these patients are getting the best care that they can get, and keeping them out of the hospital and obviously not dying from their asthma. And then we need to adjust the therapy in a stepwise approach. So here is what the EPR4 guideline looks like. I've given you a reference if you want to spend some time on it, and I'll show you the GINA in just a bit. So in the EPR4 guideline, there's one new section that they've added in, and they've said that all individuals with allergic disorders And by the way, patients with asthma, about 85% of them have allergic rhinitis as well. In fact, their nose is often very much involved in triggering some of their asthma symptoms. So what they say is indoor allergen mitigation can really make a huge impact for people with any allergic disorder, including asthma. What does that look like? Things like HEPA filters, keeping the pets off the bed, which is hard. I get it. I'm a dog lover. I sleep in this little corner of the bed while the dog sleeps sideways in the entire bed. Do any of you have animals that you can relate to this? And I don't want to move because I don't want to disrupt her. So I'm literally in one little corner of a king bed so that the dog is comfortable, right? We can all relate to that. So when I tell people keep the pets out of the bedroom, they're like, the spouse is going first. The dog is going to stay with me, or the cat. But in any event, plastic encasements on the pillows, on the mattresses, those things, frequent vacuuming, getting the carpeting out of the bedroom, those things can really make a huge impact. But for most people, they're not going to be the end all be all, but they may make life a little more bearable. So here is the EPR4 guideline, and they break it out into 0 to 4, 5 to 11, and 12 and up. And I know that the writing is pretty tiny, but I'm going to call your attention. I'm going to see if I can get this camera to track me. I'm going to put my hand up and see if it'll follow me. Andy, is it following me? Oh, yes, it is. Woohoo. All right. So a couple of things about this guideline. First of all, people will say, how do you make a diagnosis of asthma in a 0 to 4-year-old? We make the diagnosis not based on the ability to do spirometry, but we make the diagnosis based on the number of respiratory infections that they have in a given year that require corticosteroids or are accompanied by wheezing. So if you see a lot of 0 to 4-year-olds, you might want to look that up because it lays out the criteria to make the diagnosis. But what's different in this guideline as of 2020, when it was released, is right here in the step 1 care. Step 1 is for these kids, they either use a PRN SAVA, short-acting beta-2, and we have them available in a nebulizer form. We've got albuterol in a neb. We also have inhalers that we can put a chamber on so that these kids can just take a breath over the chamber. But what's new is this bottom part right here. At the start of a respiratory tract infection, add a dose of an inhaled corticosteroid at the first sign of a respiratory tract infection. Why are they asking us to do that? They're asking us to do that to prevent these little kids from getting repeated exposure to Prelone and Orapred and those systemic corticosteroids. So if we can intervene at the onset, we now understand that inhaled corticosteroids begin to work within minutes of taking the first puff. They don't achieve their full inflammatory effect for a day or two, but there is benefit from the onset of using that medication. So there are only 2 meds on the US market that are approved for the use in 0 to 4-year-olds, inhaled steroids. They are budesonide, you know of that as Pulmicort, and fluticasone, you know of that as Flovent, which the branded Flovent is now going away. I just saw notification that the manufacturer is going to stop all production of branded Flovent and that it's just going to be generic fluticasone now. So that's where we're starting. What I also want you to know is down here under the alternatives where you see the star, Montelukast now carries a boxed warning. That boxed warning is neuropsychiatric changes, depression, anxiety, suicidality, and behavior changes. That is the drug called Singulair. We've used it for 2 decades now. Both the asthma and allergy guidelines are asking providers to avoid prescribing this medication at this time due to the increasing reports of neuropsychiatric changes. I have no idea. It blocks leukotrienes. I have no idea how it is that it's associated with depression, anxiety, behavior changes. Has anyone had this reported out to them clinically? No. So just be aware that both of the asthma and allergy guidelines have removed it, And I know that the manufacturer Merck they were the ones that originally brought this drug to market. It's now generic, but there is a very large class action suit against Montelukast, apparently, or the maker. Apparently, there has been known to be some of these issues for a while, and it has not been talked about. So take with that what you will, but we shouldn't be using them at Montelukast any longer, or starting it new in patients who have other options. So I had a nurse practitioner come up to me at a conference about 6 months ago, and she said, Wendy, I have this 13-year-old daughter. She's on Montelukast. And I said, okay. She said, she's been on it, gosh, 5, 6, 7 years. I said, okay, what's going on? She said, she's a miserable child. And I said, well, what do you mean? She said, oh my goodness, her moods are all over the place. Do you think it's the Montelukast? I'm like, nope. I think she's a 13-year-old girl. But if you're worried, go ahead and pull it away and just stop it. It's not going to harm her to stop it, probably. So take her off. But in any event, I think it's probably her hormones, having been a 13-year-old girl at some point in my lifetime. All right. So that's another big change there. And then you can see that there are different options, but that's the big one. The big two things I wanted to call out is at the sign of a respiratory tract infection, we're starting an ICS and that we're not using Montelukast. Let's go to the 5 to 11-year-old. And by the way, 5 to 11, we're using pretty much the same regimen that we're using 12 and up. But what I do want you to see here, so let's say that patient that I told you about, that we used the case study, let's say that patient was 10. Step 3 is where we would go in her treatment. Out of the gate, they want us to go to a daily and as needed low dose combination of ICS formoterol. What does that mean? That's called SMART therapy. That stands for single maintenance and reliever therapy. And formoterol is the LABA that we need to be using for this therapy. That's because it has long-acting effect, but in every other country, it has immediate, it's a quick reliever as well. So what do we do with them? There are only 2 products on the market that contain formoterol. They are Symbicort and Dulera. So we write a prescription for either one of those, and we say, you need to use this every day. And then, by the way, if you need a reliever, you're going to use the same inhaler. You're going to use your combination med as your reliever as well. That is the preferred first line in both GINA as well as the EPR4, and it's called SMART therapy. When do we then go up to other meds like the biologics, the systemic corticosteroids? If people are not well controlled, we step them up every 6-ish weeks. And then when they're well controlled, we keep them on those meds for about 3 months, and then we attempt to step people down. So as important as getting people well controlled, what's also important is deprescribing. After 3 months of being well controlled, we've calmed that inflammation down. We're going to back them down on their meds at that time and monitor for recurrence. Now, same thing is true 12 and up, but at 12 and up, again, this is where out here at steps 5 and 6 is where we start introducing the biologics. And biologics are something that are done by specialty. This is not something most of us are doing in primary care. But again, what you see in the EPR guideline is that combination ICS formoterol, both for as needed as well as daily preventive medicine. So going back to my patient, where do we go with her? I started her on an ICS formoterol combination. I said, take it every day. I'm going to bring you back in about 6 weeks. And what I want you to do is, if you need a reliever, I want you to use the same medicine. The problem I'm running into, maybe some of the pharmacists in the room can help. Tell me what you're seeing. Problem I'm running into is the insurance has a rider, a number of inhalers or inhalations that they're allowing me to prescribe, right? So what I write on the script is patient using this medicine for maintenance and rescue. Please provide 1 additional inhaler for that patient to have as rescue. I've often had to go to bat and had to do prior authorizations to get it covered. But I've also had samples of some of these meds in the clinic as well. So I'll give them a sample so that they have that as a reliever, and then they use their controller meds as well. Comments or questions about that? What are you all seeing? Yeah, go ahead.
12 and up. Is there anything about weight? Because there's a lot of kids that are, that 11, 12 that are really big kids. Would you flip them over? Or?
So the question is, is there anything where weight would make me flip a child from maybe a 10-year-old to a 12-year-old? And the answer is no. I would still follow those. And what you're going to see is, let me just try to go back one quick second. What you see is if that 11-year-old is not well controlled on a low dose, we'll bump them up to a medium dose, and then we'll go up from there. And those doses that are considered low, medium, and high are different for different steroids, and they're different for different ages. I'll show you a chart on that in a second, because what a lot of people say is, what the heck is a low dose ICS? Well, the answer is it depends on what steroid we're using. For instance, I often think about the steroid called mometasone, Asthmanex. It's a more potent corticosteroid. So if I want someone to have a medium high dose of mometasone, it's 2 puffs once a day. Whereas if I use a steroid like beclomethasone, 40 mics per puff, if I want to get them to moderate to high levels of that, they need to do 6 to 12 puffs a day. So it's not that mometasone is any better, it's more potent, which means I can use fewer puffs to get them there and to get them better controlled. And then the question is, which one do you think people are going to adhere with the most? 12 puffs a day or 2, right? So that's why we end up going with some of these more newer agents, because they don't have to take as many puffs to get to good control. So long-winded answer, but hopefully that answers it for you. And then at 4 to 6 weeks, if they're not well controlled, we move to the next level with the goal of getting them well controlled. Now, what we are flipping to in our clinic is the GINA guideline. So we're moving away from the EPR4 and we're going to GINA. Many pulmonology practices are also heading down this road. But as they say in the world of primary care, it takes 10 years to incorporate a new guideline into clinical practice. So it's going to take a long time for us to get all of our patients over to this guideline if this is the one that we choose. So one more time, I'm going to show you the GINA guideline. But what's different about the GINA guideline, everyone, is once we make the diagnosis of asthma, what determines the severity is symptoms only. So where we go with our treatment depends upon their symptoms. If their symptoms are less than 4 to 5 days a week, look at what we now give them as a rescue. A low dose ICS formoterol as a rescue only. Gone are the days we use a SABA alone. The thought is, if they're needing a SABA, they've got inflammation. So let's give them an ICS formoterol, and that is what they use as their rescue inhaler. This track 1 up here is the preferred track. And because we know that it reduces the risk of exacerbations when compared to short-acting beta-2s alone. Then what if the symptoms are on most days, or they're waking with asthma once a week? Now we're going to start them out of the gate on a low-dose maintenance ICS, and they use the same inhaler for their reliever. And we step them up, and it's in step 5 where we add the biologics and the LAMAs. And at that point, they ought to be co-managed with specialty. There are other options down here. Here's your other option. Do you remember when I was doing new drugs yesterday and I talked about budesonide albuterol being in the same inhaler? And I talked about the fact that whenever someone uses a SABA, it needs to be paired or chased with an ICS. That is down here, that if patients won't use track 1, that you could use track 2, which is an ICS whenever they need a SABA. And we go up from there. So here are your GINA guidelines. Questions for me on this guideline. So the big focus in both of the guidelines these days is to ensure that asthma is well controlled. Because if it is not well controlled, they're more likely to have exacerbations. They're more likely to end up in the ER, even being hospitalized. So how do we assess asthma control? And when are we supposed to do it? Well, we use the EPR guideline for this that says at every asthma-related visit, we ought to be assessing control. There are a multitude of asthma control tests out there. The one we've used for years is called the ACT, Asthma Control Test. It is 5 questions that we ask, and the maximum score is 25. Anything under 20 means they're not well controlled and we need to step up their care. But what some people are now moving to is a test, an asthma control test called the AIRQ, AIRQ. And what it also incorporates into the guideline, into the questioning is not just their symptoms, but have they exacerbated or been hospitalized? So pick a tool to assess control. And what does asthma control look like? Asthma control, if you're using the EPR4 guideline, looks like this. They must meet every one of the criteria in the well-controlled column. It looks like albuterol or short-acting beta-2 less than twice a week, less than 2 times a month nocturnal awakenings, not interfering with normal activity. Also, their peak flow or their FEV1 is 80% of predicted. They're having 0 to 1 exacerbations a year. One of the things that people don't realize is how many exacerbations patients are having, because patients go to urgent care. And we often don't know in primary care. The only way I now know is I have an EHR system that is bidirectionally interacting with your pharmacy claims. So I have this little cute button that says fill history, and everything that the patient has filled at a pharmacy in the last year that I haven't prescribed is in bold and dark black. So when patients say, I'm not on any meds, I say to them, you're not on anything? Oh, no. Tell me about the oxycodone. Well, what do you mean? Yeah, the oxycodone that you picked up 3 days ago? Well, how do you know that? I said, I have this cute little button. It tells me everything that people have filled at pharmacies within the last year. And you know what's great about that, I'll say? It keeps me from killing you with a drug that you didn't remember to tell me you were taking, and me give you something else that will harm you. But I love it also because people come in so many times to us in primary care, they have 0 idea what their meds are. And people are getting their meds at so many different locations, the mail-aways, or they're going to 3 different local pharmacies, depending upon price. It's really scary stuff. So 2 exacerbations or prednisone fills in a year kicks them into the uncontrolled. So if any one of these boxes is checked in the not well controlled, we need to step up their care. Here's the test we use in our clinic, and we have it on a dry erase laminated form in the clinic. So when we do an asthma visit, the patient can just circle their answers, and then I'll just import them into the system so I can track it over time. But we add this up, and anything 20 or greater suggests that they're well controlled. This is just one example of a control test we use. So the short-acting beta-2s, we are getting away from these because the evidence is really emerging that repeated use of short-acting beta-2s, A, increases the risk of exacerbations, and we don't know what the mechanism is, but there's a lot of discussion about the impact that these agents have in the airways that can worsen asthma inflammation. And so we're getting away from using these only as needed. This includes exercise-induced asthma as well. So we're using the combo agents before they exercise. One albuterol inhaler contains 200 inhalations in it. A person who's well controlled, previously, if you're using the SABA alone, 2 puffs at a time, 2 times a week is 4 puffs in a week, 50-ish weeks in a year. 1 asthma inhaler should last these individuals an entire year. And I see providers writing for 3 with 1 refill. And if something happens to that patient, we have no leg to stand on, because the guidelines are very clear. 1 rescue inhaler should last a well-controlled patient 1 year unless they were using it for exercise. So I have a number of patients who say, can you please give me 2 inhalers? And I'll say, well, why do you need 2? My parents are divorced. I want to keep 1 at mom's, 1 at dad's. I'm good with that. I just put it in my note. Or I want 1 at the school nurse. I'm good with that. But giving 3 at a time, you have no idea how often they're using them. I don't care if their insurance covers 3 at a time. What I say is we give 1 at a time so I can monitor your asthma severity and whether you're well controlled or not. So SABA as a reliever is associated with worse outcomes. You saw that in both guidelines when compared to an ICS combination as a reliever. So let's now get into the controller meds. It used to be that we started everyone out of the gate on a single agent ICS if they needed a controller drug. Those days are also over. Both of the guidelines say ICS LABA is really where we ought to begin. It is more effective than an ICS alone. But ICSs are the most effective anti-inflammatory. They block 6 different inflammatory mediators. And when they're used and used on a regular basis, they are very effective for patients with asthma who need better asthma control and airway inflammation reduction. Lots of different products that are out there. Many of these are becoming generic, and some of them continue to be branded. But I told you this earlier, and I wanted to show you this. This is in the EPR4 guideline, and I love this. It tells me what constitutes low, medium, and high dose for 0 to 4, 5 to 11, and 12 and up. So for instance, budesonide, 40 mics per puff. Beclomethasone, 40 micrograms per puff. You see it's not approved for 0 to 4. But let's say I need that 5 to 11-year-old to have a medium intensity or medium dose, 160 to 320 micrograms. So how many puffs is that? That's 4 to 8 puffs to give them a medium dose of beclomethasone. And then if I needed a 12-year-old to have a medium dose, it is going to be 6 to 12 puffs a day for a medium dose. And that table is it's a comparative daily dose table that is in the EPR4 guideline. I keep this hanging on my desk so I know when I start a particular inhaler, how many puffs that individual needs to give them the low, medium, or high dose that is recommended based on their level of severity. So the question becomes, what do these inhaled corticosteroids do over time? There is some degree of systemic inflammation, systemic absorption, and we know that the higher the dose, the more systemic absorption we see. This was a study on 100 children that were given mometasone, one of the more potent corticosteroids. This was a nasal mometasone, and they followed these kids over the course of a year. And what they found is in 1 year, there was no difference in height in kids who used the inhaled steroid versus kids who were on placebo. At the end of the day, we do know that they are linked with cataracts as well as glaucoma and the potential to impact bone density when used long-term. But kids who don't breathe don't grow well either. So it is weighing the pros and cons. I would rather have my son on an inhaled corticosteroid than repeated systemic corticosteroid bursts. So we've got to weigh the pros and the cons. The funniest day of my entire career, I have to share this story with you. It should make a few of you laugh. So I always wear heels to the clinic when pre-COVID. And that day I happened to have heels on that were probably 4 inches tall. And I'm kind of behind the wall and I'm working on my charts. And I hear this man come up to the front desk. He is screaming and he's shouting at the receptionist, I want to speak to the owner of this clinic. She gave my child a medicine and my child is never going to grow above 5 feet tall. So I come around the corner and I'm like, sir, how can I help you? He's like, who are you? I said, I'm the owner. How can I help you? He said, you prescribed my daughter. I think she was on Advair. You prescribed my daughter a corticosteroid. And I saw online that's the reason she's going to not grow above 5 feet. He said, I just saw the endocrinologist and she tells me that's going to be around her height, 5 feet to maybe 5'1". I said, well, let me take you into a room and let's talk about this. I look in the chart. I see no prescriptions in our clinic for Advair. I said, sir, we're not prescribing Advair. Well, one of you is, no. Your child's seeing a pediatric pulmonologist. It's the pulmonologist who's doing that. But I said, sir, these are systemic corticosteroids. She's on a low dose. I said, let me call the endocrinologist. Let me see what she says about this, and I'll get right back to you. Well, as I'm talking with him, I am not making this up. His face is yelling at my breasts. He is literally coming mid-chest to me. And I thought, so I get the endocrinologist on the phone. I said, Dad's hotter than a hare. He thinks we've caused his child to be 5 feet tall. She said, Wendy, it's really hard to get a 6-foot girl when dad is 5'1" and mom is 4'9". It is not the corticosteroids that caused this kid to be short. It is the fact that dad and mom are both short statured. You are not going to grow to be 6 feet tall. So people read lots of things out online and they believe it, right? Google MD is what we call it. So there are impacts, but we need kids to breathe as well. So Gina says when we start an ICS, it always gets paired with a LABA, and formoterol is that LABA. In the world of asthma, we never give a LABA without pairing it with an ICS. Now in COPD, we do. LABAs are used monotherapy for people with COPD, but in the world of asthma, they are not. Formoterol is preferred, again, because in other countries, it is a reliever drug as well as a controller. The FDA never gave it the reliever status here in the US, but guidelines have the ability to do whatever they will based on the evidence. And so it does work quickly and probably is the safest based on the evidence of all of the LABAs. There's also salmeterol out there that is used in the world of asthma as well, but the boxed warning with regard to asthma death with the LABAs has been modified. The thought was always, if you bind the beta-2 receptor sites with a long-acting beta-2 and that person needs a reliever, they're not going to bronchodilate as well. Well, this boxed warning, as long as it's paired with an ICS, there is no increased risk of death, particularly with formoterol. So here are your combination products out there. And there are a bunch of them that are on the market. These are combo products that are actually approved by the FDA for asthma. So we talked about Montelukast. I talked about the warnings that are now in the labeling and the boxed warning. And per the FDA, here's a quote from the FDA, the benefits of treatment may not outweigh the risks, especially in mild disease, i.e. mild asthma, or in the treatment of allergic rhinitis. So Montelukast has been used for years, and because the way it works is it blocks leukotrienes, one of the inflammatory mediators that is released, and it's approved all the way down to 12 months of age. So do I still have some kids on this? I do. Kids that I don't have other options for, or who are doing well without adverse events. But I'm not really starting anyone new. It's actually really well tolerated in general, and it doesn't really have any drug-to-drug interactions. Now let's go to the monoclonal antibodies. You cannot turn on a television these days without seeing advertisements for all of the different monoclonal antibodies that are out there. These products range around $6,000-ish a year, depending upon the product. But I will tell you, I have a patient in my clinic who was hospitalized 9 times in 2 years for asthma, was on a ventilator twice in those 2 years. She is on a biologic, and it is a life changer for her. So for the people who need these, for many of them, when we identify what is the component that is affecting their asthma, is it interleukin-6, is it eosinophilia, is it IgE, we identify what is probably driving their asthma, and then a particular product is chosen. Probably omalizumab is the one most of you are most familiar with. This has been out for 15, 20 years. It's the drug called Xolair. And not only do we use this now for asthma, moderate to severe, and this is in children 6 and older now who have moderate to severe asthma and a positive skin test or in vitro reactivity to a perennial arrow allergen. So this is IgE and weight-based. It used to be that kids had to go to an allergist or a pulmonologist every 2 to 6 weeks to get injected with this, and adults as well. It's now available in a subcutaneous injection. So people can give their own omalizumab at home, provided that they have no history of anaphylaxis and have been on this product. Its newest indication is chronic urticaria. So we see it being used in people with hives as well. And it's a recombinant monoclonal antibody, binds to IgE, so it's an IgE antagonist. That's why we look at IgE levels, we look at weight, and that's how it's based. Probably the one you're seeing most ads for these days is the drug called dupilumab, known as Dupixent. Not only is it indicated for asthma, it's also now indicated down to 6 months of age for babies with severe atopic dermatitis. So we're seeing it used in that arena as well. But there are lots of them on the market. The last class of drug that we're now using in the world of asthma are the LAMAs, the long-acting muscarinics. The one that has been approved, historically, these are drugs we've used for COPD. They bind and inhibit the muscarinic 3 receptors, which promotes bronchodilation. What I also like about LAMAs is they dry up some of the mucus, so people tend to be a little less mucousy because of their anticholinergic side effects. So the one that was first approved is the drug called tiotropium bromide. That's Spiriva, but people are using others as well. Asthma guidelines say these are added on in step 5 and step 6 in people who are already on a LABA, ICS, and are not well controlled. And tiotropium is approved all the way down to 6 years of age. We've got one triple drug inhaler that is also available. I mentioned this in the new drug lecture. It is a LAMA, LABA, and an ICS. The only problem is it does not contain formoterol. It contains vilanterol, which is not the preferred agent, LABA. And this could never be used as smart therapy because vilanterol does not work quickly as a rescue. So I mentioned fractional exhaled nitric oxide. Probably it was 10 years ago that the representative for this device came into my clinic and asked if I wanted to purchase one of these devices. I think it was around $10,000 at the time. And both, neither the early GINA nor the EPR4 were really talking about this yet. But it was in 2020 that we began to see the introduction of this information into the guidelines. And the thought is that we measure nitric oxide on exhaled breath, and it's believed to be a measure of airway inflammation. So where am I seeing this being utilized? I'm seeing this being used in kids 0 to 4, kids who can't do spirometry. I'm also seeing this used in a patient that we just cannot, despite the bronchodilation, get them to meet the criteria for asthma. So we've done the testing in the clinics, and they still are not meeting that diagnostic criteria. So this is kind of one additional test that we can use to lock in the diagnosis. So here's the thought. The higher the fractional exhale nitric oxide, the greater the airway inflammation. In children, if the levels are over 35 parts per billion, PBB, 5 to a 12-year-old, and over 50 in adults, then it is a marker of airway inflammation and helps to support the diagnosis of asthma. It's just an additional add-on piece in those people that we're just on the fence with. The problem is that allergic rhinitis, which so many of these folks have as well, also drives up inflammation. So if there's a lot of airway, if there's a lot of allergic rhinitis, we have to interpret these results cautiously. If you want to know what it looks like, this is what the device looks like. It's very easy to use. It's like blowing into a straw. It doesn't require a lot of effort, and a lot of coordination. And my last little comment to you is that the GINA guidelines in their guideline, they published an algorithm on managing asthma exacerbations. And what I love about it is they talk about how do we do this in primary care. So we want to assess the patient. Is it asthma? And how severe are they? Well, they're considered mild to moderate if they can talk in phrases. If their respiratory rate is increased, but the pulse remains under 120, we look at O2 sats. And here's the other key. The peak expiratory flow needs to be greater than 50%. If any one of these criteria is not present, like they can't speak in sentences, their respiratory rate is greater than 30, their O2 sat is below 90, or their peak expiratory flow is under 50%, they should be treated in an urgent care ER. Otherwise, we're going to give them a short-acting beta-2 with ICS, prednisolone. And the treatment for prednisone is 40 to 60 milligrams a day for 3 to 10 days. 40 to 60 a day for 3 to 10 days, we no longer need to taper. As long as we're treating with prednisone for less than 14 days, no taper is necessary. I don't waste my time on a Medrol dose pack. It's not high enough. It's not long enough. And I don't waste my time on the 60, 60, 60, 50, 50, 40, 40. People have no idea what they're doing. And they forget where they are and they make it up as they go along. 60 a day or 40 a day every day. And in kids, we use 1 milligram per kilo per day. In kids, we do BID dosing as recommended. In adults, we can do the prednisone once a day in the morning. And then we make sure that they have albuterol ICS combo available to them, or formoterol ICS combo as well. So let's go to our questions, and then I'll take any questions you have, and we're going to go to a quick break. Which of the following is true about the use of anti-inflammatory therapies in patients with asthma? Systemic corticosteroids are an effective low-risk treatment. Anti-inflammatory airway effects of ICS do not occur until 2 to 3 days of consecutive use. For patients with mild asthma, SABA-only rescue therapy is preferred to ICS containing rescue regimens. And adding an ICS to a fast-acting bronchodilator for rescue or rescue and maintenance therapy results in fewer exacerbations compared to a SABA only. What's your answer? D, good job. And the last one, which of the following is true about SABA in patients? SABA-only rescue therapy is recommended for patients with mild asthma in the GINA report. Increasing SABA use is associated with a higher risk of exacerbations. SABA and ICS rescue therapy is equally effective for preventing and treating exacerbations as SABA only. There are currently several FDA-approved SABA-ICS combinations available in the US. Answer? Number 2, short-acting beta-2s, when used alone, increase the risk of exacerbations. All right, what questions do you have for me on asthma? Yes, ma'am. Yes. So the app that I use, it's embedded in my EHR system. And it's something that you all pharmacists have talked to me about. There's a name that allows for bidirectional interfaces. Does anyone know what it's called? I can text my practice manager. I forget what it's called. It's part of my EHR system, so we don't have to add it on. It's part of our all scripts system. But there is a name, so I will text her and ask her if I can get a name.